Welcome to the Radiology Economics and Policy Learning Electronic Toolkit, Replete. This program was made possible through a GE Healthcare RSNA Education Scholar Grant from the RSNA Research and Education Foundation. I'm Rich Duzak from Emory University, and this session is entitled Radiology Reporting, Trainee and Teaching Physician Considerations. This module is targeted to Level 1 of the Diagnostic Radiology Milestones Project of the Accreditation Council for Graduate Medical Education and the American Board of Radiology. But some of the material will address issues related to professional versus technical billing and compliance matters, and thus contribute to your learning at Levels 3 and 5 as well. Milestones levels differ for the various ACGME-approved radiology training programs, and so if you are in a program other than diagnostic radiology, please reference the Replete resource webpage for mapping this module to the correct level for your individual program. The learning objectives for this module are as follows: to understand differences in how Medicare approaches payments to practicing physicians versus physicians in training, to outline the documentation requirements for teaching physicians to bill services to Medicare when trainees materially participate in those services, and to implement systematic approaches to ensure regulatory compliance when receiving reimbursement for services rendered at teaching hospitals. There are a number of very bureaucratic and not so easily readable references available from CMS, so I'll draw your attention to a former JACR column of mine for those who seek additional information on this topic. The references in that article will provide even wonkier information for those who seek more nuanced regulatory details. We've talked previously, and will continue to talk about the various steps necessary to ensure appropriate reimbursement for radiology services. In the prior documentation modules, we have focused on reporting information necessary to support ICD diagnosis information and CPT service and procedure information. That's information that you will need to include in your reports. That information is necessary so that our coders can do the best job possible on the back end and translate our documented work into appropriate reimbursement. As we have also talked about and will continue to talk about through Replete, our coders, and down the road, our auditors potentially, will often be reading our reports. And so our documentation needs to be done in a manner that they too can understand. Structured reporting is just one part of the systematic informatics and team-based approaches to capturing necessary information that is necessary to get us paid. As we'll talk about in this module, those same approaches will also help us all ensure regulatory compliance. And that's why many of us who lead practice reimbursement activities advocate the use of templates. They remind you to put things into your reports that you might otherwise forget during a hectic workday. And they also permit your practice leaders to update those templates when the regulatory environment changes, so practicing radiologists don't need to worry about each and every one of these details. If you use templates in the manner that we have described, they will permit you to get paid appropriately. And they will also, as we'll talk about in this module, help you stay compliant with Medicare and other payer rules, and keep your practice squeaky clean in the event of an audit. For services rendered by trainees in a teaching environment, they are particularly important in this regard. Before we get into the weeds of documentation requirements for services rendered by teaching physicians in conjunction with a trainee, it is important to provide some context. And so let's take a few minutes and talk about how physicians get paid for their services, because it differs for trainees and practicing radiologists. In fact, it differs quite a bit. Some physicians view Medicare as having a big pot of gold, just waiting to get distributed into their paychecks each month. But it's pretty rare for Medicare to pay attending physicians directly with a check right from the carrier. And it almost never happens for residents and fellows in ACGME designated official training programs. In reality, Medicare pays our employers, which may be our faculty practice plans or our hospitals, and that intermediary healthcare entity then pays us, the physicians, each month based upon the salary structure that we have mutually agreed upon. How that money flows, however, is vastly different for faculty radiologists versus trainees. We'll talk more in future modules about the differences between professional and technical payments, as well as how bundle payments are structured. But for the purposes of this talk, it is important to know that Medicare typically pays physicians out of a different bucket of money than it pays hospitals. The dollars for radiologist services, and most non-radiologist physician services as well, come from the Medicare physician fee schedule. But the dollars for inpatient hospital services come from the inpatient prospective payment system. Relevant to this talk, then, is that the attending physician payments from Medicare come from that professional slice. The payments for ACGME program trainees, and that's most of the learners in Replete, come from the very separate and bigger buckets of money that goes to hospitals. The fact that there are two separate buckets of Medicare money that pay trainees is the reason that this whole topic is important. Let's talk about how each of these groups, faculty and trainees, get paid. We'll talk about this in much more detail in future modules, but Medicare money to pay attending physicians comes from its Part B physician fee schedule. Those payments are typically assigned by the physician to that physician's healthcare system or faculty practice plan, which then gets those checks from Medicare and processes them, and typically pays those physicians on a monthly basis. Those payments from Medicare are largely on a per-click, transactional, per-study basis, which means that the more you read, the more that your health system gets paid. Payments to support trainees also come from Medicare, but they come from two different buckets of money. Direct GME payments are paid in a bundled payment amount per approved resident. Indirect medical education payments are paid on a per-click basis for each patient from Medicare admitted to the hospital. Those dollars together, along with a component from your health system, pay your salaries if you're a trainee. So let's talk about those Medicare payment groups separately. Medicare Direct Graduate Medical Education, or DGME payments, are the ones on the bottom left of the last slide. Medicare doesn't pay your health system for teaching you per se, but rather it compensates your health system for the costs related to resident teaching. You see those listed here. Some examples: the stipends and fringe benefits for residents, the salaries and fringe benefits of faculty who supervise those residents, and the costs of clerical personnel who work in your GME administrative office. These are all paid on a per-resident amount, meaning the more residents a program is approved for and has employed, the more it gets paid. Indirect medical education, or IME payments, in contrast, support patient care. They recognize the differences in care costs between teaching hospitals and non-teaching hospitals. For example, the former need to support the newest and most advanced services and equipment to support their research and educational missions. And in addition, teaching hospitals typically provide uninsured patient access to specialized care, much more than non-teaching hospitals. In contrast to direct GME payments, which are paid on a per-resident basis, IME payments are paid on a per-case basis, meaning that they're added as a premium to what Medicare pays the hospital for each admitted Medicare patient. The bottom line with all of this is that Medicare pays for my work as an attending and your work as a trainee out of different buckets of money. And like the old Seinfeld episode where George was caught double dipping, Medicare doesn't like double dipping as well, meaning they don't want to see funding from one bucket go to support the other. So they prohibit me as an attending from billing for a service that was provided only by my resident. That is, if you as a trainee interpret and sign a report, and I didn't even look at that study, then you did all the work, and I can't bill for it. Again, because I didn't do any work. For me as an attending physician to be able to bill for that service, I need to perform my own unique work and document it accordingly. And so, this is why we use language like this that you see here in our health system. We require our faculty to use the language like that on the very top here for every diagnostic imaging service rendered by a resident that they staff. And we require language like that at the bottom for every invasive procedure performed by a trainee that we staff. And the reason that we have different language for each of these is that there's different rules for each of these: diagnostic imaging versus invasive procedures. And so we'll talk about each of those separately. Medicare's rules for teaching physicians billing for diagnostic radiology services are both explicit and clear. Here's what Medicare says. Medicare pays for the interpretation of diagnostic radiology and other diagnostic tests if the interpretation performed by or reviewed with a teaching physician. If that resident prepares and signs the interpretation, the teaching physician must indicate that he or she has personally reviewed the image and that the resident's interpretation, and that he either agrees with it or edits the findings. And Medicare will not pay for an interpretation if the teaching physician only countersigns the resident's interpretation. Note that this is not optional. Again, Medicare will not tolerate attending physicians getting paid for work that trainees alone performed. Thus, attendees must, as I've highlighted here, provide appropriate documentation. Because without it, as I've also highlighted, Medicare will not pay for those services. The rules for interventional radiology are a bit different. The images we generate all need to be reviewed and interpreted, as I've already mentioned, and documented accordingly. But interventional radiology services are special because they are considered surgical services by Medicare. And so when teaching physicians bill for procedures provided by or in conjunction with their residents, compliance with Medicare's surgical supervision requirements now becomes necessary. What does that mean? For anything other than very minor procedures that we'll talk about in a minute, Medicare states that in order to bill for surgical, high-risk, or other complex procedures, the teaching physician, meaning the interventional radiologist, must be present during all critical and key portions of the procedure and be immediately available to furnish services during the entirety of the procedure. For surgical services, present means in the operating room, and in our case, the interventional radiology suite. Not in the locker room, not in the cafeteria, and not in the doctor's clinic across the street. Because surgical services vary considerably, Medicare doesn't micromanage defining the critical and key portions of the procedure. Attending physicians get to define which parts they are for their individual cases, and their definitions, though, will need to pass external scrutiny in the event of an audit. And then they really need to be present for those parts. Ideally, if they are not present for the entirety of the procedure, they should be documenting which components they were actually present for. Some examples. Deploying a biliary stent during a biliary drainage would be considered critical and key. Stitching the biliary drain to the skin at the end of the case, probably not. But physicians tend to focus too much on that critical and key phrase and not read on in the Medicare regulations to the part about minor procedures. Here's what the agency says. For procedures that take only a few minutes, 5 minutes or less is what Medicare defines that to be, and I believe that to be Medicare's definition of time. We'll talk about that in RBRVS modules down the road, to complete and involve relatively little medical decision-making once the need for the operation is determined. The teaching surgeon must be present for the entire procedure in order to bill for the procedure. Again, for minor procedures, this means present in the suite, not in the reading room down the hall. But unlike for major procedures, Medicare defines for minor procedures the part where attendings need to be present. And those parts are the entire procedure. It's in black and white in the regulations, or on my slide, now in red. And so when I, as an attending physician, work with a trainee in diagnostic situations, I use language like the one at the top. These images were reviewed and interpreted by Dr. Duzak. And when I, as an attending physician, work with a trainee in procedural situations, I use language like the one you see at the bottom. Dr. Duzak was present for the entirety of the procedure and reviewed and interpreted these images. These statements indicate that I knew the rules and that I am attesting that I followed those rules. So back to the flowchart. This is all part of my work, which I document in my report, and how I communicate to my coders what I did, so that they can then code my reports appropriately. Again, as we have talked about before, our coders work on the back end of all of our reports and translate our language into what we did so that we can get paid appropriately. And templates help us do just that. We focused on prior modules on getting paid, but staying compliant with Medicare regulations is equally important. Our coders need appropriate documentation to understand what we did to translate it into appropriate codes. We talked about ICD codes and CPT codes in prior modules. But there is another type of code that gets attached to CPT codes. They're called modifiers, and they're particularly important in the setting of teaching physician services. Modifiers are 2 digits that are appended to CPT or HCPCS codes to indicate the special circumstances in how that service may have been rendered and/or billed. So some examples. 26 modifier after a code indicates that it's for a professional component of the service, meaning the radiologist's interpretation. TC is for the technical service. That's what your outpatient imaging center bills. 53 is used to report a discontinued service. So you had a complication in the middle of a procedure and you had to bail out. It reports to Medicare. You did some of the procedure, but not all of it. For services rendered by teaching physicians, those services are appropriately indicated using the GC modifier. You can read what Medicare says here. The GC modifier must be entered for teaching physician services rendered in compliance with all of the requirements outlined. So your coders only know that you actually did all those things if you document them appropriately. And Medicare only knows that you did all those things because the GC modifier is attached. What does this mean? It means that when your coders append a GC modifier to any CPT code, now I've just put some zeros here, but you know what the other 5 digits can be in that place, your attending is attesting that he or she performed the service as a teaching physician in conjunction with a resident, and that attending physician met all necessary participation, supervision, and documentation requirements. GC modifiers allow claims by trainees to be uniquely identified, and that means that they enable more than just getting paid. They can also, interestingly, enable research. And so it was this requirement that allowed our team at Emory to study trends in modality-specific services performed by radiology residents nationwide over the last decade. You see here, for example, that radiography, mammography, and ultrasound services by residents have all remained relatively flat. But services for MRI, and even more so for CT, have grown quite a bit. So aside from getting paid, there are other downstream implications of capturing all this information with the correct modifier. But the most important of these, in the teaching physician setting, is for regulatory compliance. Again, Medicare says that the GC modifier must be entered for teaching physician services rendered in compliance with all of the requirements outlined. The corollary to that is that billing a service to Medicare rendered by a trainee out of compliance with all of these requirements could be construed as a false claim. And false claims, as I'll tell you about in a moment, can get you fines or even jail time. This is serious stuff. This whole teaching physician issue came to light back when I was a fellow, actually, in 1995. I was there at the University of Pennsylvania when it was the poster child for the PATH audits, the Physicians at Teaching Hospitals audits. Penn, like some other institutions, was audited by the Office of Inspector General, and that agency concluded that some of the university's teaching physicians had inappropriately billed Medicare because medical records did not adequately document their involvement in services provided by trainees. That audit led to Penn entering into a settlement agreement with the government for $30 million. You see the other universities initially audited here. And these big dollar settlements catalyzed the government into auditing many more institutions over the next several years. It was a result of this scrutiny and these big fines that most of our academic departments now pay a lot of attention to this. And most of us have processes in place, many involving attestation templates, like the samples that I have shared with you. You may say that's all remote history, but the issue remains very much alive today. You see here a snapshot of a recent press release from the Department of Justice about an academic radiology department that recently paid the government over $2 million to settle one of these cases. The allegation here is the very issue we've been talking about. The government alleged that certain attending physicians certified that they had reviewed the images associated with interpretive reports prepared by resident physicians, when in fact they had not even reviewed those images. And it's not just the university that was held liable. 2 faculty radiologists were personally charged in these cases. You see here another press release about the 2 attendings who pled guilty and who both potentially faced jail time. I'll let you read this excerpt yourself. Again, this is serious stuff. We're talking about potential consequences of as much as 10 years in federal prison. The point here is that the government does not tolerate double dipping. Neither does our practice, nor hopefully does yours. The point in all of my comments here is that with regard to this issue and all other billing issues, we need to be doing the right things for the right reasons. While I'm focusing on documentation, remember that documentation itself is not the goal. Doing the right thing is the goal, and documentation is simply the attestation that we have done the right thing. Templates are a really good way to remind us day in and day out, for each and every case, what we need to be doing and what we need to be documenting. As we talk more about emerging pay-for-performance models in future modules, I think you'll see how using templates in a similar manner will help you meet those increasingly onerous documentation requirements as well. It's what you need to do to get paid appropriately, and also to remain compliant with the mountains of regulations that are imposed upon all of us as practicing physicians. So in summary, Medicare pays attending physicians and physicians in training out of separate funds, and will only pay the former when their services are rendered in a very specific manner. Noncompliance with teaching physician rules is essentially double billing and could turn a claim into a false claim, which makes it subject to fines and/or imprisonment. And finally, systematic approaches to workflow and reporting will help ensure compliance in both process and documentation. To ensure appropriate credit for this module, please make sure that you complete the accompanying online quiz from the RSNA's e-learning platform. More information on the Replete initiative and additional resources are available on the RSNA's website. I'm Rich Duzak from Emory University, and I look forward to helping you continue along your economics and health policy milestones journey. Again, thank you for participating in Replete.